Hello everyone. In this video, I will talk about a topic which is very important from the theory point of view as well as from the entrance exam point of view, which is osteosarcoma. Now, osteosarcoma is a malignant primary bone tumor. It is malignant and it arises from the bone. The main age group that it's seen in is 10 to 20 years. So it will be seen mostly in children of 10 to 20 years of age, and it is the most common bone tumor in children. If we talk about the location, the part of the bone that osteosarcoma arises from is the metaphysis. So it arises from the metaphysis part of the bone, and the main sites that it is seen in are the lower end of femur, upper end of tibia, and the upper end of humerus. So lower end of femur, upper end of tibia, which are the corresponding bones, and upper end of the humerus. Next, now osteosarcoma can be classified. Based on the clinical setting, it could be either primary or secondary. Primary meaning that it is arising from the bone itself. It is not due to some any other problem. It is it is a primary tumor, and this is seen in children of age 10 to 20 years. So, if it's seen in a child of age 10 to 20 years, it is primary, arising directly from the bone, whereas a secondary osteosarcoma will have some sort of a predisposing cause. It will be seen in people of age 40 to 60 years, so in older adults, and there will be some underlying cause. It could be either Paget's disease or a condition called multiple enchondromatosis or fibrous dysplasia or radiation exposure. In the presence of these conditions, the secondary osteosarcoma might develop as a secondary malignancy. So, this is the classification based on clinical setting, primary or secondary. Now, based on histology, that is the main type of cells that are seen in this tumor when we do a biopsy, it could be osteoblastic, chondroid, which is predominantly cartilage, fibroblastic, which is predominantly your fibroblasts, and telangiectatic. So, based on histology, it could be osteoblastic, chondroid, fibroblastic, or telangiectatic. So, if you look at the clinical features, there will be swelling. The patient will complain of a swelling, which will be because of the tumor in the bone. Then the patient will also experience pain. There might be a history of trauma, and there might also be pathological fractures. So these are the clinical features. If we do an examination, we will see a bony swelling, and if we palpate it, it will be warm, tender, with ill defined margins. So the skin over the swelling will be warm, there will be tenderness, which means the patient will complain of pain when we palpate it, and the margins will be ill defined. Then there is the skin over the swelling is shiny because the skin becomes extremely stretched because of this swelling. So the skin over the swelling becomes very shiny, and veins will be prominent over the swelling. Prominent veins might also be seen. If we look at the pathology, I mean, if we take the section of the tumor and we cut it grossly, what we see is a gray, hard, gritty tumor. So it will be very gray, hard, and a gritty sort of a tumor. Diagnosis is by X-ray. So what we see on an X-ray is two characteristic features. First is a sunray or a sunburst appearance. As you can see over here, the calcification of Sharpey's fibers in the bone will give a sort of a sunray appearance. These look like rays of a sun coming from the tumor. So this is called a sunray or a sunburst appearance, which is due to calcification of the Sharpey's fibers. Then the second characteristic appearance is a Codman's triangle. This Codman's triangle is due to a periosteal reaction. So when there will be a tumor underneath the bone will try to grow around it to limit the spread of the tumor. This is called a periosteal reaction. What will happen because of this periosteal reaction or this excessive bone growth is that the cortex will become raised. The bone cortex over here will become raised, and it gives a sort of a triangle like appearance, which is called Codman's triangle. So, this Codman's triangle is due to periosteal reaction, which leads to raising of the cortex, forming this bony triangle called Codman's triangle. Other investigations that we can do are serum alkaline phosphatase, which is going to be raised. Then we can do a chest x-ray for lung metastasis, since osteosarcoma, the primary site for spread is lungs. And then for other spread to other parts around the tumor, we can do a CT or an MRI. Now in treatment, we can do amputation, which leads to complete removal of the local tumor. So the we look at the local tumor and we completely remove it by amputation. Or if it is diagnosed early and if it is small, we can do a limb saving surgery also. Now, if there is micrometastasis, we do a chemotherapy. Chemotherapy, the drugs given are methotrexate, citrovorum factor, cisplatin. These kind of chemotherapeutic agents can be given, and this is given for micrometastasis. So, what the treatment algorithm usually is that first neoadjuvant chemotherapy is given before the surgery to reduce the micrometastasis and to reduce the tumor size as much as possible. And then we do a surgery so that now we can remove the tumor, and after that adjuvant chemotherapy is done to prevent recurrence. This is the algorithm over here. Neoadjuvant chemotherapy before the surgery to reduce micrometastasis and the size, then surgery, then adjuvant chemotherapy. Prognosis, the main site of spread. Okay, one very important point to be remembered here is that osteosarcoma is radio resistant. It is a highly radio resistant tumor. So there will be no use of giving radiotherapy in this tumor. The only way to treat it is by chemotherapy and surgery. Radiotherapy is going to be useless. Now, if we look at the prognosis, the main site of metastasis is the lung in osteosarcoma, and even after treatment and removal, there is a high chance of recurrence. Now, if we look at the treatment and the 5-year survival with surgery as well as chemotherapy, the 5-year survival is 70%. So, 70% 5-year survival with surgery and chemotherapy. But if only surgery is done, with surgery alone, the 5-year survival reduces to 20%. And without treatment, the patient will die within 2 years of development of the tumor.